Thank you, Kathy. I'm Abigail Tumpy. I'm Associate Director of Communication Science for CDC's Division of Healthcare Quality Promotion. And with me is Nicole Coffin. Nicole is a deputy of our communications team. And while they're getting the slides up, I'll just do a little bit of introduction. So Nicole and I have actually been here in the agency for over 15 years now. And I think at this point, we've seen every major public health event, going back to the intentional release of anthrax, to SARS, to H1N1, to a variety of healthcare issues, including the large fungal meningitis outbreak last year. And one of the things that we specialize in is actually helping healthcare facilities and public health talk about infections. So you know that moment that you really dread of when you're in the spotlight and all of a sudden you or your healthcare facility has to talk about healthcare-associated infections, or maybe an outbreak that may be going on. Maybe you have a patient notification. God forbid you have, drug diversion within your healthcare facility. We're going to give you examples of how to work through those events. And no matter the circumstance that you may be going through, the communications pathway that you actually do and the steps that you take are all going to be consistent. And I know some of you are looking around for slides, and so for those of you who don't have slides, there are some in the back, so you can take them home with you when you leave for lunch. But if you want to take some initial notes here, then you can grab some slides afterwards. So we're going to give you examples of how to talk through public reporting of healthcare-associated infections, patient notifications during infection control breaches, emerging threats to patient safety, and preparing your facility staff and chain of command to discuss healthcare-associated infections. And so Nicole is actually going to kick us off and talk about the communication landscape in which we operate in right now. Nicole?
So the communication landscape for healthcare-associated infections have actually changed a good bit over the last 10 years or so. They, as you know, generate a lot of significant press. The science is complex, and all of these factors combined create a need for really strong risk communications. Also, there has been a trend towards state legislation to increase the transparency around public reporting of healthcare-associated infections, which I know the folks in this room are very aware of that. And also, there's been an evolution of transparency with patient notifications, a lot of those happening, and a lot of move to really being transparent about what's happening in healthcare facilities. So we actually thought we would take this slide and point it out to you, because one of the things that's interesting about healthcare-associated infections is if you look at these two lists, they're actually lists of factors that help people absorb risk. There are things that are part of the left side that would help them accept a risk more, and things on the right side that are less accepting risks. And you'll notice that with healthcare-associated infections, many of the characteristics of those fall on that right side. It's being controlled by other people. When you're in the healthcare facility, they might not necessarily know you, which makes it difficult to have trust. And all of those things become big factors when it comes to trusting people when you're going into a healthcare facility.
And so to be transparent, when we work with healthcare facilities, oftentimes folks are concerned about if we're transparent, people are not going to trust us. Our patients are not going to trust us. And actually what we're going to try to convince you of is the opposite, that you can actually be transparent and use transparency to earn and maintain trust of your patients, of your clientele, of any of your constituents in your community. And so we have boiled down a lot of risk communication science into kind of easy, plain language examples. And so, but the basic premise of this is that risk communication literature defines 4 factors that determine whether the public is going to perceive a messenger as trusted and credible. And those are if the person shows empathy and caring, honesty and openness, dedication and commitment, and competence and expertise. So we're going to give you an example of 5 healthcare facilities in different scenarios that actually have demonstrated these factors: empathy and caring, honesty and openness, dedication and commitment, and competence and expertise. And so let's talk through these 5 risk communication principles that we're going to go through, and we're going to give you these 5 examples. The first is that you need to acknowledge the situation. So if you actually don't acknowledge the situation, people will think you're not aware, and they'll actually start rumors. You need to convey empathy, as we said. So messengers are considered trustworthy when they demonstrate those 4 factors. You need to ensure transparency, so be frank, honest, and open. Trust and credibility are difficult to obtain, but once you lose it, it's almost impossible to get back. Do your homework and brief your colleagues. We're going to give some good examples of how you can do that in your current role. And be ready and have a plan. And I know that you may think, this is not going to happen to our healthcare facility. And what we end up happening, 9 times out of 10, many facilities that we consult with had not really thought through some of these scenarios that they might have to communicate on. And really, in your role of knowing the infection data, knowing the infection control principles, there's going to be someone like us in a healthcare facility, a communicator, who's going to be coming to you asking for guidance on how do we communicate on these things. So let's go through, let's talk a little bit about what patients are actually feeling. So we mentioned this a little bit in the beginning, but patients may feel fear, loss of trust, lack of control. So you have to give patients and their healthcare providers action steps. You have to acknowledge uncertainty and honestly admit if information is not known, but let them know what you're doing to find out that information and when you're going to come back to them with an update. And you have to acknowledge emotions. So patients may be angry about the situation. Be sure to empathize and even apologize in some situations, and send the message that you're working hard to get the situation under control. And I think this picture from the Denver Post, this was actually from a patient notification in Denver from Rose Medical Center, in which there was a scrub tech who was actually diverting narcotics. And it was 6,000 patients who ended up getting notified. And in this particular circumstance, Rose Medical Center, they were up against all odds. If anything could go wrong in a patient notification, they potentially had all of the factors that were working against them. So in this particular circumstance, because there was a federal investigation, the police came out and made an arrest. And so the local paper said that they were going to start publishing this. So it really kind of forced the hand of Rose Medical Center to come forward and do a press conference. They ended up doing a press conference on Thursday night. Friday was July 4th holiday, which meant there was no mail. So they potentially had to basically go forward and say, there's up to 6,000 individuals who may have been impacted by this, and you'll receive letters next week. So this, believe it or not, what happened then, what you can imagine, is that hundreds of people showed up at the healthcare facility that weekend. And so they had to put systems in place very quickly to kind of work around this factor. They were pushed to basically come forward before the letters were going out the door, and they also were working against this time frame of not having any mail that you would actually use to be notifying these patients. Let me give you an example of a patient notification that was from years ago, but actually was fantastic, and we use it as the basis of what is now our patient notification toolkit. So this was actually at Broward General Medical Center, and in their communications pieces, I'm going to read you the quote that they used. It says, "We realize that you turned to our medical facility to get better. This event is intolerable to us, and we want to work with you to resolve the situation and ensure your safety and well-being. We are taking steps to ensure that this event never occurs again in our facility." So what did they demonstrate? Empathy and caring, honesty and openness, dedication and commitment, competence and expertise. And their patients and the media, everybody trusted them that they were getting that situation under control. A great example of a successful patient notification. CDC then actually took these letters and we tested them with patients, and patients resoundingly appreciated the information that were in the letters. And that's actually the basis of what's included in our patient notification toolkit, which we're going to talk about in a minute. Let me give you another example. And this is an example of turning poor outcomes into an area for improvement. This is actually Cincinnati Children's Hospital. And if you actually have ever read the book from Atul Gawande that's called Better, there's a whole chapter in there about cystic fibrosis centers. And they started looking at their outcomes. And Cincinnati actually thought that they were one of the best in the country. And when they started looking at their outcomes, they realized that they weren't. And so they took a very novel approach. They actually held a town hall with all their patient families, and they basically said, these are the outcomes we are getting, but this is what we're going to do to improve. And they laid out a step-by-step plan of how they were going to work with the patient families and the community to improve the outcomes for their patients. And you know that they did not lose a single patient in that process. They used transparency, and they worked to build and maintain trust. So this is actually an ad that comes from, it was in Delta Sky magazine, and they've done a series of these ads right now, but I'm going to read this to you. With a mean lung function of 97.4%, our outcomes for cystic fibrosis are among the best in the country. Why? Because 10 years ago, we thought our CF program was strong until we compared ourselves to other children's hospitals and realized just how far behind we were. Why? Because our programs needed to get better, and only by learning from other CF programs and being transparent with our patient families every day could we start building better protocols together. What does that make you feel? It makes you feel like you would trust sending your child to this healthcare facility. What did they demonstrate? Empathy and caring, honesty and openness, dedication, commitment, and competence and expertise. One more example, and then I'm going to turn it back over to Nicole. So we actually work with investigative reporters around the country. We had an investigative reporter contact us, and this particular reporter was interested in doing a story on using data from Hospital Compare. And this particular state didn't have public reporting of healthcare-associated infections prior to this point. So this was the first time individuals in this state were actually getting to see data from their hospitals. And so this particular reporter, she took 3 hospitals. Hospital A, which had the highest infection rates. I'm going to use the word rates. This is technically really SIRs, okay, but I'm going to use rates for just ease. But basically, Hospital A had the highest infection rates, and they had reputation challenges. Hospital B had the lowest infection rates and were not very well known. And Hospital C had mediocre rates, but they had the best reputation in the area. And so she called all 3 hospitals, and she said, I want to come and sit down and have a 1-hour conversation with whomever I need to speak with about the infections in your healthcare facility, okay? Hospital A had her sit down with a very high-level administrator. And this administrator was new to the healthcare facility, and this particular person said, there's no excuse for infections. You'll hear people make excuses for infections. There's no excuses. And here's what we're going to do to fix it. We've changed our program. We've worked to improve. And these are the steps that we're going to put in place to make sure we continue to provide safe care for our patients.
They really saw it as an opportunity to talk about what they were doing.
Yeah. So Hospital C, then, that had mediocre rates, but the best reputation, they actually spent 50 minutes of the 1 hour providing excuses. The data's no good, NHSN is no good, the definitions don't work, we have sicker patients. By 50 minutes into it, the reporter said, you've given me 50 minutes of excuses. Do you want to tell me what you're doing about your infections? And Hospital B, instead of bringing 1 person to the interview, brought 12. And they filled an entire conference room of people. They had people from critical care, from wards. They had nurses and doctors. They had even environmental services in there. They had such a variety of people. And basically, they started the conversation by saying, infection control is not one person's problem. It's all of ours. We all have to work together. And so this reporter called us back and told us about this experience. And what do you think she did? She said originally, she always went to Hospital C because they had the best reputation, and that's who she felt like she could trust. But after this experience, she kind of lost her trust with that particular facility. She certainly, hands down, would go to Hospital B. But honestly, she even felt trust for Hospital A as well. So there's an example of how you even communicate it to media or to constituents about what's happening in your facility and how it can really make a difference.
So the reality is that all of us are going to become patients at some point, if we haven't already, or certainly if it's not us, it's going to be someone that we care about. So the picture up there is my father with my mom and my 3 cute kids, taken a couple years ago. And I was actually in the situation of being that consumer. So I had talked to my dad. He was about to prepare for major heart surgery, and he had a conversation with his doctor who said, we were going to have a 1% chance of heart attack, a 1% chance of stroke, I think he said a 1% chance of death, and a 30% chance of infection. And my dad's telling me all this. And I said, what? What do you mean 30% chance of infection? What exactly did he say? And he said, well, he actually said it's no big deal, it's totally normal, and we'll just handle it. And I said, okay, I'm going to call you back. And so I sat with that, and then I thought, yeah, I'm going to look up this hospital and Hospital Compare, because I knew that I could get some data there and just see what it shows. It was interesting. It showed an SIR for C. diff of about double, like it was like 1.9, and then an SIR for CLABSI that was significantly lower than the nation. So I realized some shortcomings, especially for the C. diff, because it was the first quarter data. And I thought, I need to have a conversation with somebody. So I proceeded to call up the hospital and start trying to get in touch with the IP. The difficulty of trying to get in touch with the person through the operator we'll have to talk about some other time. But I finally got in touch with this person, and by the time I reached her, I had lost a lot of trust in this facility based on this conversation that my dad had relayed, the difficulty of getting to the person, and also just the scariness of the numbers. And to be honest, she was fantastic. She immediately was empathetic and talked to me about how, I know this is pretty overwhelming and probably scary. Let me talk to you about what this data is, because this is my data. I totally know it like the back of my hand. And she proceeded to walk me through bits and pieces of it. But the most important thing was that she said, all of this aside, let me tell you what we're doing to keep your dad safe. And then she talked about collaboratives that were happening in the hospital, particular techniques they used, like chlorhexidine bathing and things like that, which were somewhat familiar to me. And through this conversation, I actually had an experience where not only did she take the time to correct some of the misinformation about the 30%, and even said, I have a feeling, I understand where that's coming from. I'm going to call this doctor. I talk to him all the time. Think he's just a little bit confused about the details. But she actually built a lot of trust with me and instilled actual confidence. And it really turned the tide about how we approached this surgery, and it relieved a lot of fear we had. And the truth is it should be the same way that you talk to consumer advocates when they call you. They're probably coming from a place of fear. They might be coming from a place of misunderstanding, and you have an opportunity to influence them. It's not always easy. I certainly was not an easy person to talk with on the phone that day. I mean, I grilled this poor woman. But she really stayed positive, and she was fantastic. So at some point, you're either going to be the person on the other end of that phone call, or you're going to be called into a meeting to deal with some of the things that Abigail talked about, whether it be data, patient notifications, diversion. And it's really important that you be ready. We chose the slides of Atlanta because I think all of you guys were aware of the kind of criticism and, frankly, the mocking that happened for Atlanta, because they were not ready for something that seemed to the rest of the country pretty obvious that it might happen at some point. You might get some snow. And the way they handled it really revealed that they weren't ready, and there are a lot of things that you can do to make sure that you're not in that position. I would say if you could do nothing else, think through some scenarios you think might happen that you might be included in. Identify who you would need to talk to in your facility. I don't think you necessarily have to develop a whole communications plan, but the day a crisis happens should not be the first day that you meet the communicator in your facility. You should know who this person is. That person could be really helpful to you in a difficult situation. And the more they know about this topic, the more they can hit the ground running and rely a little bit less on you to actually write a lot of content. So building trust within your organization takes time, and that gets back to that previous slide. Even picking up the phone and trying to figure out who that communicator is will save you a lot of time. She keeps pulling me back to the microphone. So what can you personally do? I would say out of this list of always doing your homework, dialoguing as much as possible, probably the most important thing is to always keep in mind what Abigail touched on earlier, that element of communicating empathy, showing your dedication. You're all dedicated. You're here for a reason. And also, one thing I always tell our folks in our division before we have to speak with media or even partners or other folks is take a minute to think about, what are you most afraid of getting asked? And actually think through what you want to say. You'd be amazed how many people know exactly what they're afraid to get asked, but they never take the time to actually figure out what they're going to say. So while there's not a crisis happening, it's a good time to think through what that message would actually be for you. So we know this is a lot of information, and one of the things that we tried to do at the end of somewhat last year was to compile this in a toolkit. And so we can make it a little bit easier for folks. And that culminated into a project, the Patient Notification Toolkit. And what we did is we took lessons learned from patient notifications across the country. We also took some of our experiences, whether it be things like I was deployed during anthrax, during SARS. You know, Abigail's done a ton with emergence of new pathogens. Together, we tried to bring our expertise to this process and think through what people would need to know. And really, one of the things we filled this patient notification toolkit with was actually practical tips and templates of things that we had already written and used. And most importantly, as Abigail mentioned earlier, we actually took the time to pull letters that had already been used by facilities, and we actually took them to patients in a couple states and had them look at them, and we focus group tested them. And I think the first two columns, folks did fairly well in. This last column is the one that people really struggle with. It's really important, I know we keep saying this, but it's really important to your patients that you are empathetic and you're even apologetic about what happened. I wish this had never happened, or this is intolerable to us, or we're sorry that this is happening to you. And also recognizing that the information is scary. Even a line that says, we know this is frightening, goes a long way for patients to know that you're thinking of them as a person instead of a potential lawsuit. And assuring them that things are going to be taken care of is also important. Giving them places to go, actions to take with this fear that they have. So we're going to take a little bit of time to talk through a most recent example where we had to draw on all of our different experiences and really pull this all together, and that was during the outbreak of fungal meningitis and other infections, which Abigail and I co-led the communications response for the agency on.
So if you're not familiar with all the details, let me just take 30 seconds to kind of walk you through what happened in this particular outbreak, and then we're going to talk a little bit about what we did. And the reason we chose this one is there were a lot of people who were externally wrote about CDC and wrote about public health and our response, and so it gives kind of a good example of, you know, external critiques of how this all could potentially come together. So first of all, on May 21st, 2012, contaminated steroid injections were produced by New England Compounding Center. By September 18th, the first meningitis case was reported to the Tennessee Department of Health. On September 25th, 7 more patients were identified by Tennessee Department of Health. All were treated at the same ambulatory surgical center. And so at this point, Tennessee and CDC were really trying to put the pieces together and get a better understanding of, was this a procedure-related event that was associated with this one facility, or was this something to do with a medication? By September 26th, NECC voluntarily recalled 3 implicated lots of steroid injections. By the 27th, we knew we had something bigger on our hands when the North Carolina Department of Health informed CDC of a patient with similar symptoms to those to Tennessee. By the 28th, state and local health departments started to work with clinical facilities that administered medication to begin contacting exposed patients. And by October 4th, CDC activated our emergency operations center. We did a national press conference, and FDA confirmed the presence of fungus in unopened vials from NECC steroid injections. By October 6th, NECC expanded its recall to include all products distributed from the facility in Massachusetts. And by October 15th, FDA released an alert stating that they could not really say that the rest of the products produced by NECC were truly sterile. So we started looking at even other products outside of these initial implicated lots. By the 18th, CDC announced that the fungus was actually exoral So this was the first time we'd seen exoral in patients before, so we were really up against something that was clinically different. And by October 19th, more than 99%, so a month, from start to finish, 99% of the patients who potentially had been exposed had been contacted by local, state, or CDC personnel, informing them of the risk to get tested. And I think before we jump into this, we have to understand that this was a tragedy for 14,000 patients. So these are stories like Diane Reed, who is a 56-year-old caretaker of her wheelchair-bound husband. She became the 3rd Tennessean to die of fungal meningitis. And the story of Diane is actually quite a sad one, where she actually hurt her back when she was lifting her husband in and out of his wheelchair. And she tried all of these other things, yoga, massage, and eventually turned to steroid injections, unfortunately got contaminated steroid injections. George Carey was the 65-year-old husband of Lillian, who lost her life to fungal meningitis. And unfortunately, as George was grieving the loss of his wife, he realized he too was one of the cases and had fungal meningitis himself. And he still is battling his symptoms. He has been in and out of the hospital throughout the last year. So although we'd had significant past experience with patient notifications, most of the notifications we've done in the past were around bloodborne pathogen issues. So this was really something new. We had a large geographic spread. We had 23 states that had received one of the 3 contaminated lots. This was a really rare event. We had not had extraohilum in individuals before, and the severity of the illness was extreme. I mean, many of these patients were having strokes and dying before they were showing up to, healthcare facilities to officially get diagnosed. And so we knew we needed to work very fast. But we also knew that this was going to be really scary for people. And so during patient notifications, one of the things that we've learned from our past notifications is that you have to give clinicians and patients action steps. You have to give them back control of the situation and let them know, here's the things we need you to do. So one of our outreach strategies was ensuring that patients had necessary information. So for the first time, we actually provided the names and locations of facilities that received product on a clickable map on CDC website. So you literally could click on the map, see if your facility had received it, and have the contact information from the facility. So patients knew exactly what to do. These are their 3 actions. Check and see if your facility is listed, call the facility, see if you got this product. If you did get this product, do the next step of go get tested. We actually put information out in English and Spanish. We received thousands of calls. We monitored and responded to social media. So we actually did a kind of a novel thing with social media, where most times when CDC has an event, we usually push a lot of information out via social media. We felt like we are already contacting most of the patients who were impacted by this. So we took a little bit of a different approach. We actually monitored social media to see who was tweeting about this, and then we'd tweet back. And give them a message back to let them know, here's more information, or here's the answer to your question. So kind of turned it around a little bit different than how we've used it before. And we based it on outreach from the previous formative research that Nicole mentioned. Our media strategy, we basically swung open the doors of CDC and let media in. We did multiple press conferences. We invited press to CDC for tours of our emergency operations center or our laboratory. We also told the media, you will hear from us every single day at 2 p.m. And at 2 p.m., like clockwork, our website was updated, the information was sent out to partners, and then instead of waiting for media to call us, we knew at this point all the reporters who were covering this topic, we started calling them and saying, the information is out. This really kind of built a very strong relationship with a lot of media on this. We also gave them, because this was such a scary event and we knew that this was such a novel disease, we wanted to make sure that people had some sort of visuals that they could use. So we immediately provided a B-roll package and still images, and we had a digital press kit that we updated on a regular basis. We provided Spanish spokespeople so that CNN and Espanol was able to actually cover this, for example, as well. In reaching clinicians, we reached out to over 245 professional organizations. We provided 10 health alert notices. We updated 4 treatment guidelines on a regular basis. We held multiple conference calls with clinicians. We actually facilitated a mechanism for clinicians to ask questions and get answers. So let's say that you're a clinician and you have a patient who has fungal meningitis. You were able to call CDC and say, I have a patient and I need a consult, and we were actually able to connect you to a fungal or infectious disease expert in your region that could potentially even come to your hospital and consult directly in person on that patient. So this was an entirely new service that we had never kind of put in place before, and we basically kind of called upon all of our clinical partners to help us in that. And we enlisted a lot of public-private partnerships, so things like Medscape, et cetera. So here's the response that we got from people on that. So here's a few. I'm going to read you a couple of these quotes. When a dangerous disease outbreak hits the social media, the connected generation trusts some government agencies more than others, and Twitter users tend not to panic. CDC has done an excellent job in communicating this story to clinicians and patients alike. From the website to FAQs to clinical webinars, the CDC has been transparent, clear, direct, and timely. When it comes to a public health crisis, the public apparently wants to know what the CDC has to say. And then this one, I'm actually going to read you what's on the bottom left here. He actually starts off this blog by saying, it's not often I come across situations that involve crisis communications, public health, social media, and reputation management, but I have one today, and it's a doozy. This was a doozy. This certainly was a situation that could have spun out of control, but here's the overall message that this individual said. The CDC has spent buckets of time, money, personnel, and resources on establishing themselves as a credible, plain language, accessible, available source for health information. And now we're seeing the results of that effort. In a crisis, the public and the media are turning to them for updates and the latest news. If you want to be trusted in a crisis, you have to build that trust before a crisis, and there's no shortcut for doing that. So I think this is a great example of all these pieces that you could do right now before you're in a crisis. Coming up with a plan, identifying who you need to be working with some of those partners, having a conversation with your communications person to say, how are we going to communicate on this should fill-in-the-blank event happen?
Really, the bottom line is that there are things that you can do to be successful. And it's not easy. It's not always something that happens overnight. But you can take small steps right now to begin that process. The keys to success, just to recap, are being transparent by demonstrating transparency, listening and being compassionate in your messaging, also, staying ahead of the communication curve. We haven't spent a ton of time talking about that, but that's important as well. You do not want a communications vacuum to happen, whether it's being what you say to your C-suite or what you say to the media or your clinicians or your partners. Telling people what's happening is really important. And then Also building trust in advance of a crisis and ensuring in that building trust process that you are collaborating with key stakeholders. And then also just knowing that if you do this work on the front end, it really helps when you are in that crisis situation to be able to respond quickly.
And then at the end of the day, if you have an event happen in your facility and you don't know what to do, give us a call. Because this is what we're here for. We consult with numerous public health entities, healthcare facilities. Nicole has even just recently worked with a healthcare facility that had one of the largest documented CRE outbreaks, and they had to do a patient notification associated with that. So, I mean, the information that we provided you today, the step-by-step process that you would go through, is going to be consistent no matter what is happening within your healthcare facility. And because we've used it time and time and time again on so many events, whether it be, high infections reported on, public reporting, to an actual outbreak, to a patient notification, et cetera. This information, it works, and it is important to make sure you have that in place when you do this. So I think we'll be happy to take any questions or comments that you all may have. And I know, don't everybody get up and leave, because you don't get to leave for lunch early, because after we're done, Dawn has some additional updates, so you can't run away yet.
She said, make sure you tell them that.
Any questions or comments?
You have a question here? If you could go to the mic so everyone can hear as well.
I'll just make a comment for perhaps some of the IPs in the room to thank you, because I know you become our lifeline when we are dealing with these things locally. And I can remember back to SARS when things would change literally by the hour, and yet we were so desperate for information to help guide us. So we know you've spent years building upon this, and it continues to go in the right direction, and we thank you for your resources.
Thank you.
Thank you.
We recently had I'm Doris, I'm from Nevada. We recently had a situation in our counties that our primary care, where we had a litter of 10 puppies that were exposed to rabies. And we had...
She's a rabies expert.
Oh, right. Well, that's the R word to me now. I don't use that word if I don't have to. But we were put up against, we were updating our social media sites and our websites with information we were getting from our health department. And we'd get a message like, okay, they've identified eight of the 10 puppies. The original puppy was positive for rabies. The other 8 have been identified. They've been euthanized. They've all been sent out for testing, including the mother. And so they're waiting for the results to come back. So we'd put that out on our media sites. And then the next morning, the news report from the health department would say they've only isolated 4 puppies, and the other ones, and nobody's been euthanized. So the information that we were being given was not the same as what the media was being given.
Yeah.
And so it kind of, after like the first couple of days, we just shut up. Yeah. We're just, we're referring everything to, because the communication was so awful, and it was contradicting itself all the time. So when you get in the middle of that, what kind of advice do you have?
So this is a really great example, and I think it goes back to, you have to be talking to people in advance of a crisis. You can't make friends in the middle of a crisis and think that you're all going to be on the same page, right? So you have to come up with strategies of thinking through in advance. Who would we need to be working with if something happened? Do we even know the local health department? Do we know the state health department? Do we know who would be the person we would be working with? And I think kind of thinking through that up front is critical. We tell public health, we tell facilities, you all need to be working off the same talking points. Everybody. There needs to be one person who's, compiling all the talking points and making sure all of the key players are getting those talking points, so that anybody who gets a media call is getting that exact same thing. I think, we said in the beginning, we've kind of been around here for a long time, and so we feel like we've seen everything. And to give a rabies story, we recently just had a very rural hospital have 43 bats sightings inside the hospital. And so believe it or not, all of the stuff we talked you through today is all of the stuff we talked through the hospital with, dealing with how do you notify patients, how do you figure out, what you're saying to the media about bats within your facility. If you have bats in your facility, it's very possible you have other infection control issues, right? So how are you going to discuss that with the media and the community as well? And so, again, the things that we talked through could work for any situation. And then one last point on this is we didn't really talk about how you build those relationships and the partnership strategy, but Nicole mentioned the need to work with consumers. And CDC is actually, we've done a very conscious effort to work with patient advocates. We actually have regular phone calls starting back 5 years ago with Consumers Union. We have, a dozen plus patient advocates who come here every other year for meetings with us where they have a sit-down conversation with CDC about what we're doing on healthcare-associated infections. And in many cases, these were individuals who years ago were even doing things like lobbying against us. I mean, we didn't really see eye to eye. And I think as we started working more closely together, we really came to the realization that we're all working for the same goal, right? And ultimately, that can really also serve as a feedback loop to you. But when we talk about how do we approach partners, I kind of like to think of it as 3 circles inside one another. And we call it know, like, trust. They know you, they like you, they trust you. And you're not going to have everybody kind of move into that trust category, but they're going to probably move throughout that paradigm. But you have to slowly but surely have some of those relationships that you're building, again, in a non-crisis where you can move them into that trust category so that if you should get into a crisis situation, you're able to hit the ground running. Did you have anything to add to that?
So I would add 2 things. On the consumer point, we recognize that this is not easy. It was not easy for us. It took a long time. And so we don't want to suggest that these are things that you can simply just flip a switch and then all of a sudden you're having great regular conversations with consumers. We know that this is difficult. The other thing I think that you mentioned that comes in my head is it goes both ways. We're actually trying to encourage the health departments also to do this same work and reach out to you. So it's not just you reaching out to them. It's also them remembering that hospitals and healthcare are part of public health. They're the people who actually treat the patients. And I would say that they should have been bringing you in as well and talking through this is what we're going to do. We might have numbers that change, so please let people know this is a dynamic situation and the numbers are going to be changing as we get additional information. We might have to update our information. So there is a lot of opportunity for improvement in the example that you gave.
Any last questions or comments? Okay. Oh, yeah, go ahead.
If the meningitis outbreak had happened a year later during the government furloughs, would you have still been actively involved as you were?
What are the talking points on this? Yeah. Nicole and I were both furloughed. We would have been called back. Certainly, it would have certainly slowed our efforts because we hit the ground running. Tennessee called us, I think, September 21st or something. So we hit the ground running very quickly, starting to come up with a communications plan on this. And by the time the Emergency Operations Center activated, I mean, we were working, I don't even know how many hours. We missed every family event for a good, 10, 12 weeks. Yeah.
I do know that during the shutdown, there was, I think, a foodborne outbreak, and the communicators were part of the team that were called back, I believe. Yeah. So there's a recognition that, crisis communication is important as crisis response.
Hi, I'm Peg from upstate New York. And to speak to that point, that happened during ID week, and we had many speakers scheduled to speak from the CDC, and there wasn't a hesitation in the program. Either we did web streaming or they found alternative speakers, and the program, I thought, went off without a hitch. And another comment I have is you said don't wait for a crisis to build relationships. in our facility, in our community, what I found is sometimes it's a slow news day, and they'll call us and say, oh, flu season's coming, and I think they just need a filler for the local evening news.
Yeah.
And when the antimicrobial soap issue came out, so sometimes, and we contacted them, like when the movie Contagion came out, we talked, so for many years we've been building this relationship, so hopefully we'll never have to call them in the middle of a crisis, but like you said, there's some nice, easy, light ways to develop relationships. So
Yeah.
thanks.
Great examples. Okay, thank you all for your time.